Hi, I am Dr. Amit Maidev and I am the chairman of the Institute of Gastrosciences at the Reliance Foundation Hospital in Mumbai. And I would like to talk to you today on upper GI endoscopy in this special step course of ASI for surgeons to learn the technique of flexible GI endoscopy. Now, flexible GI endoscopy has grown and evolved over the last 6 to 7 decades, starting with fiber optic endoscopes and slowly moving on to video endoscopes. And today we have come to a situation where the latest model flexible GI endoscopes are video endoscopes which have got high magnification, high resolution with various other image enhancement capabilities by which we can pick up early malignancies in the upper or the lower GI tract. Now, as I described to you the procedure of upper GI endoscopy, I am going to go through 3 steps. Number 1, I am going to talk to you about the parts of a normal upper GI endoscope. So, now if you can see here, this is how an upper GI endoscope looks, and what I am holding in my hand on the left side is called as the control section. So, this is the control section. Then this tube, what you see here coming out from the control section going ahead, is called as the insertion tube, and this is called over here as the connecting tube. So, the connecting tube goes behind and it gets attached to the endoscopy processor and light source. So, from which light is being supplied, which comes through various fiber optic cables through the control section into the control body, connecting tube to the control body, and then comes out again by fiber optic cables or by electric cables to the tip of the endoscope. Now, the tip of the endoscope is extremely important because at the tip we have got a very tiny camera. Now, this camera has got a high magnification capability, and by pressing certain buttons on the control body, we can also increase the magnification or increase the resolution of the image that you see. Now, if you were to see the control body over here, you focus over here, you have got 2 wheels. You have got one small wheel and you have got one big wheel. So, the small wheel, when you turn it towards us, that is up, actually the endoscope tip is turning to the left. When you turn the small wheel ahead in the front, the endoscope tip turns to the right. Whereas the big wheel, when you turn it towards us, then the endoscope becomes up, whereas when you turn it away from you, the endoscope goes down. So, by turning the small wheel and the big wheel, we can turn the tip of the scope in different directions. And as you see here, you can actually rotate the scope in a complete 360 degrees only by turning and a combination of the small and the big wheel. So, you see these are the parts of the scope. In addition to that, you have got 2 buttons in front of the endoscope. Now, this button, the lower one, which is marked by blue, from here air is coming out from this processor and the light source, which is also supplying air, because the upper GI tract or the lower GI tract, they are potential cavities. They are not containing air all the time, they contain fluids. So, when you put an endoscope inside the stomach or the colon, you have to inflate it. So, for insufflation, you need to insufflate air. So, in normal circumstances, for normal upper GI endoscopy, we normally insufflate regular air, unless we are performing some interventional procedures where instead of air, we start instilling carbon dioxide inside instead of air, room air. So, air is continuously coming out from this button. So, when you are going to do the endoscopy, our left thumb is going to always remain on this button, so that this hole which is at the tip gets covered and the air gets transmitted to the tip of the scope, and that air goes inside the stomach. Whereas the upper button is the suction button, by which you can suck the fluid which is there inside the lumen. Now, when you just put your finger on it, nothing happens, but for activating the suction, you have to press the button. So, Normally we just keep the finger, the middle finger is kept on the air is continuously coming out, whereas you can see your index finger is kept on the upper button. It is just placed over there, and once we are inside, if you want to suck some fluid, you have to press your index finger, by which suction can happen. So these are the various parts of a scope. Once more I will tell you, this is the control section. Ahead you see is the insertion tube, which is going inside the patient. Behind you see is the connecting tube, which is going inside the processor and the light source. And that is the light source and the processor. There is a cold light, so the tip of the endoscope, from where the light is coming out from the camera, it does not become warm. It is a cold light, because until that light gets transmitted, there is no heat which is generated. And this is now a camera. This is no more a fiber optic system. It is a video endoscope. So now these were the parts of an endoscope. In the next section, I am going to show you how to handle and how to hold the endoscope, in which position to position the patient to perform an upper GI endoscopic procedure. So I am going to describe to you now the actual procedure of upper GI endoscopy. So for upper GI endoscopy, we call the patient on an empty stomach for at least 6 hours, and then we usually perform the procedure under total intravenous anesthesia called TIVA. So the patient is made to lie down on the bed in the left lateral position, and then we attach a mouthpiece inside the mouth so that the patient does not bite the endoscope. This mouthpiece is fixed to the neck with this elastic band. The patient is already sedated, and now, as I described you before, we are holding the scope in the left hand with my 2 fingers. My middle finger is on the air water button, and whereas my index finger is on the suction button. Now the first thing I am going to do is to fix the small wheel in the center. So now if we focus on the tip of the endoscope, you see here when I am moving the big wheel, the scope is moving in an up-down fashion. Now to make it move in one single plane, I keep the small wheel in the center and fix it, because this is the knob to fix the small wheel. Now if you see, if I am moving the big wheel up and down, the scope is moving in only one plane. So now I bring the big wheel towards me and I turn the scope in this direction. So now if you see here, when I am moving the big wheel away, the scope is going towards the back of the patient. When I am moving the big wheel towards me, the scope is coming towards the anterior abdominal wall of the patient. So in this position now, I am going to start the actual procedure. You see here now, I am going to pass the endoscope with the moving the big wheel with my left thumb little bit away so that I go above the tongue. Now you can see on the endoscopic picture that I am going above the tongue. You can see now, and I am moving gently as I am going inside. I am turning the big wheel towards me so that I am going just behind the tongue until I come to the cricopharyngeal area. Now once I come to the cricopharyngeal area, you can see the vocal cords, you can see the cricoid cartilage on one side, the other side, and on this side there is one pyriform fossa which is on the left of the patient, and this is on the right of the patient, the right pyriform fossa. If I pull the scope back, you can see the epiglottis. So with this now you can actually even examine the supraepiglottic portion by turning the big wheel up, gently going here, turning the scope with your right hand, turning the shaft. I am holding the shaft of the scope, that is the insertion tube of the scope, with my right hand. Now keeping the scope in this position, I am starting the suction now, and keeping the scope in this position, now I have to go along one of the pyriform fossa. I am going to go along the left pyriform fossa. I am passing the scope, turning the shaft of the scope slightly to the right and gently pushing it inside. By going inside, now you see that I have entered the esophagus. Once I have entered the esophagus, now I am going to release the brake or the locking of the small wheel, so that the small wheel now becomes free. So now what I am going to do is, you can see here, by turning the shaft of the scope to the left and right, I can rotate the scope. By moving the big wheel up, big wheel down, I can go either up or down and see each and every area of the esophagus. Now as I am going in, I'm going to gently go along the lumen of the esophagus as if you are driving a car through a tunnel, making sure that you don't bang onto one of the walls, always remain in the lumen. Now, after entering the esophagus, there are certain things which we need to observe. Number one is whether the esophagus is containing any contents like fluid or food. If it is containing fluid or food, that indicates that there could be some functional or organic obstruction in the esophagus. Here, of course, you can see there is a clean esophagus, there is some froth. You start studying the mucosa. You also see whether there are any peristaltic wave. You can see that intermittent peristalsis is happening in the esophagus. So that means this esophagus has got a normal peristalsis. I keep on going along by turning the shaft. You can see below at 12 o'clock position there is a bulge. That is the bulge of the spine. Then I keep on going ahead and keep on turning the scope by moving the control section with your left hand and turning the shaft right and left. As I keep going ahead, I slowly come to an area which is the esophago-gastric junction. Now see here now, I am gently passing the scope inside, go there, and at this area now you can see there is a change in the lining. Below you can see the lining is pink, above the lining is little pale. The pale mucosa is the squamous epithelium of the esophagus, whereas the pink mucosa is the columnar epithelium of the stomach. So here you can see is the esophago-gastric junction and the Z line. It is also called as the Z line. Whereas almost at the same level you can see the diaphragmatic pinch. So that means this patient does not have a hiatus hernia. If you find that the Z line is above and the diaphragmatic pinch is below for at least 2 centimeter gap, that is an indication that there is a hiatus hernia. Now after going in the stomach, if you turn the shaft of the scope to the left, you go towards the fundus. Now first thing I am going to do, you see my left index finger now, I am going to suck the fluid which is there in the fundus, so that the chances of this fluid coming up and aspirating are reduced, because these procedures we usually do under sedation. And now once I have sucked out that fluid, now I pass the scope inside, and as the scope is going, now see what I am doing. I am slowly turning the shaft of the scope to the right and my body to the right. So automatically now the scope has got oriented towards the antrum of the stomach, and I am going along the greater curvature of the stomach. Now if you see the stomach here, on the right side is the lesser curvature, left side is the greater curvature, above here is the anterior wall, below here is the posterior wall. So now I am going along the greater curvature, go here, go here. Now you have to know that I have to go to the right. So again I am turning the scope to the right, turn the big wheel up by turning the big wheel towards us, and keep on passing the scope until I start seeing the antrum and the pylorus. You see now that is the pylorus. You see the pylorus from far, push the scope in little bit and make the big wheel little bit more up, and you start seeing the incisura angularis. This is the incisura angularis. It's very important to inspect the incisura angularis, because most of the malignancies in the stomach, they occur on the incisura angularis, and if you have a non-healing gastric ulcer on the incisura, you should take a biopsy from that. So this area should be well inspected. Now the first thing is to keep on going towards the pylorus by keep on passing the scope in a long loop position, keep the pylorus in the center, and then at one particular point you enter into the duodenal bulb. You see now I have entered the duodenal bulb, and in the duodenal bulb, this is the common place for duodenal ulcer. So either you may have an ulcer on the anterior wall of the duodenum or posterior wall, or you can have on the right side or left side. Now if you were to inspect the lining of the duodenum, you can see these are duodenal villi. This is not a flat lining like the stomach. You can see almost like a villus pattern here. But once I have entered the duodenal bulb, how to enter the second part of the duodenum? So pass the scope little bit in, and now I am turning the small wheel to the right, body to the right, and the big wheels gently up. See what I have done? Small wheel right and big wheel up. And by doing that, I enter the second part of the duodenum. This is the second part. So now the scope has turned the junction between the first and the second part, and the left hand side you can see a small bulge there. That is the ampulla of Vater. So that ampulla of Vater on an end viewing scopy you will not be able to see properly, but you can see it as a bulge there. So now this is how we are recognizing we have entered the second part of the duodenum. And then if I straighten the endoscope, which has formed a loop inside the stomach, by paradoxical movement, the scope is going ahead, even though I am pulling the shaft of the scope back. So this is only because now I have straightened the loop which has occurred into the stomach, and with this I have advanced further inside the duodenum. So in some patients who have got chronic diarrhea, who you want to rule out whether they have celiac disease, you want to take some biopsies from the second part of the duodenum, this is the place from where you have to take the biopsy. So now I'm going to pull the scope back until the scope slowly slips back into the first part of the duodenum. Again, you are going to see the ampulla of Vater on the left side over there, slight bulge is there, above. Pulling the scope back, coming back to the first part of the duodenum, and as I am coming back, the scope will suddenly slip back into the stomach. You see here, again it fallen back in the stomach. Now the next thing to do, after you have fallen back in the stomach, is again go ahead, remain over here, and at this level, turn the big wheel completely up with your left thumb. So with this now you have taken a U-turn. Now after taking the U-turn, I am turning the shaft of the scope and pulling the scope back. So in a U shape, now the scope is seeing the fundus. And I can see the esophagogastric junction. You can know whether the OG junction is lax, whether this patient has hiatus hernia. You see here that the junction is slightly lax, but the scope gripping sign is very good. So this patient will not develop a GERD. Not only that, you can see the angle of his is quite well preserved. It is not obtuse, it is acute angle. So therefore, this is the normal OG junction. So now is the time to inspect each and every part of the stomach. So again, I am turning the big wheel away from me so that the scope is falling back into the body of the stomach. So now that I am inside the stomach and I have already seen the fundus of the stomach, now in the stomach we have to carefully inspect each and every square centimeter of the mucosa. You see now what I am going to do is carefully inspect the antrum first, make sure that the mucosa is not pale, the pink color is still continuing right till the pylorus. If you find that the color in the antrum has become whitish, that can indicate atrophic gastritis. You may have to take a biopsy. And in the whitish color, in case you find any red area, that definitely requires a biopsy that can indicate intestinal metaplasia or dysplasia. So now how do we inspect the stomach? By moving the shaft, moving the big wheel and turning the big wheel up, moving slowly to the right, then again going down. And this way, while coming back, you are taking a complete U-turn and a 360 degrees rotation of the scope, and you can see the entire stomach wall properly. We usually take a biopsy for a rapid urease test to rule out H. pylori infection. So whenever we take a biopsy, we usually suck out the air from the stomach to reduce the air inside and to make the wall of the stomach a little thick to prevent the biopsy forceps from creating any damage on the stomach wall. So put the biopsy forceps, catch the biopsy, and gently pull it back and send it for rapid urease test, which is a fast test for H. pylori. So how do we rotate the scope? We turn the small wheel to the left, the big wheel up, small wheel right, big wheel down, small wheel left, big wheel up. So this is a movement which all of you should practice so that you will know that each and every part of the stomach is well visualized. So keep on gently seeing each and every part. You can see a few small hyperplastic polyps here inside the stomach which do not deserve any biopsy. And once more, coming back, we keep on sucking the air so that the patient becomes comfortable at the end of the procedure. The patient does not have a bloated tummy, and suck the air completely from the stomach by pressing the upper knob with your index finger. Gently start pulling the scope back, suck the fluid which is there in the fundus of the stomach, and then once again while coming out, we are going to inspect the esophagogastric junction. Now for this, we are going to use this technique called narrowband imaging, where you can see that these are special light filters which are attached to the tip of the scope, by which the vasculature becomes enhanced, and you can very nicely see whether there are any islands of Barrett's which are creeping up on the squamous epithelial mucosa of the esophagus. Here you can see that there is no Barrett's with the NBI, and then pulling back the scope, once again visualizing each and every part of the esophageal mucosa, making sure that this vascular pattern is normal and there are no pathologies inside the esophagus which require a biopsy, and gently pull the scope out. If there is any secretion, keep on sucking it. This small nodule does not require any biopsy. It is a submucosal bulge which is seen, very tiny one, doesn't require any further investigations. Gently pulling the scope out into the cricopharynx. And once we come back to the cricopharynx, we suck out the fluid which is there accumulated in the throat, which is around the cricoid cartilage. Once more you can inspect the cricoid cartilages, the vocal cords if required, and then gently pull the scope out. So this is how a upper GI endoscopic procedure is performed in totality, by which we can visualize each and every square centimeter of the stomach as well as the proximal duodenum.